Warm greeting from our institute. The topic is sutureless femtosecond laser assisted deep anterior laminar keratoplasty, an innovative technique. Traditionally, we all know that the DALK has been performed by manual method, by big bubble method, and femtosecond laser method using sutures. So the issues with traditional techniques are twofold. One, the suture related complications, and second is the long intraoperative time. So how to circumvent these? So we thought, can we have a sutureless technique in DALK? Can we not put the sutures? But the main problem was whether there will be a stable apposition between donor and host cornea in this technique. So we thought of doing it. We took first patient, and if you look at the depth of the opacities to the tune of 465 micron with the minimal corneal thickness as 515. This is the donor preparation. When we did the donor preparation in femtosecond laser, the diameter we took at 7.5 with total thickness as 485 micron, because we take 20 micron more than the expected depth in the recipient cornea because of detergence effect post-op. And the energy we took at 40. Now this is the donor tissue preparation. We first place it onto the this is a special type of Catina artificial chambers, and then this is the docking process which is going on in the femtosecond laser machine, that is Visumax machine, no financial interest. And this is the laser delivery into the donor tissue. And here you see there's a side cut. And this is a beautiful lenticule that we are deriving now from the cadaveric cornea. So this is the lenticule which we are going to implant, but you can appreciate that this is a very thick lenticule, because in DALK we have to go quite closer to the Descemet membrane. Now the recipient cornea, again the diameter we have taken as same as 7.5, but the thickness is 465 micron with energy setting as 40. So this is the recipient preparation. This is you can appreciate the corneal scar in the cornea. And this is the laser delivery after docking in the Visumax laser system. And this is the side cut. And now this is the recipient cornea. Now you can appreciate that we have gone very close to the Descemet membrane. Ideally in this situation, what we do after placing the donor cornea, we put the sutures, but here we have avoided that, and we have seen whether it really works, because we are going quite close to the Descemet membrane. And this is, you can very well appreciate a very firm apposition, a very nice apposition here, though we have used the fibrin glue to make it oppose instead of using the sutures, followed by placement of the bandage contact lens. So this is the post-op day 1, 7, 30 and 6 months. This is the post-op photograph on OCT. You can appreciate that we have gone almost to the tune of to the depth of Descemet membrane with 465 micron that we are expecting. The specular findings, we have found no significant changes, and till date we have done about 15 such cases with outcome as pre-op vision. If you compare, there is definitely a significant change in mean BCVA. Astigmatism is to the tune of 2.1 and with nil complications. So the question arises, is it really a DALK? Yes, we are approaching almost near 50 micron to DM. What about the edge effect? How the edges, this is the edge effect. You can see there's a beautiful apposition, no overriding or underriding. How strong is the apposition? So we have performed phacoemulsification with normal parameter in 3 of such patients, and we haven't found any popping effect in the graft. So it's a promising technique. definitely it has the ability to change the practice pattern. And of course, we require a large cohort to conclude our results. Thank you.
Very nice. I'm not discussing, but uh, don't you think your set of patients from Chitrakoot, would they be careful enough not to rub eyes? Because in refractive surgery, if you have a free flap, we are able to put it back and place a BCL, and we've never had lost flaps in
So
those
here,
days.
ma'am, the counseling is very important, I
Yeah.
think. The counseling plays a very important role.
Yes, Dr. Dham.
Dr. Look, it seems beautiful, well done. But my question is, what is the learning curve?
Learning curve is very less, sir, in this, because if you look at it's a basically machine work.
There it
It's
is.
a machine work, but yes, follow up is very important, because what ma'am was telling that they should not unnecessarily problem in post-op duration. That's very important. Secondly, we have also seen at 6 months we have performed phacoemulsification 3 of the patients, and normally we think that the apposition is not great, but here we haven't seen any popping off effect of this, so there has been apposition also.
How is the epithelial defects? Do they occur, heal, or better?
We put
That's the only
bandage.
complication we fear.
We put the bandage contact lens at post-op, so epithelial defect we haven't encountered.
When do you remove the bandage?
3 weeks post-op,
weeks.
sir. This is a normal protocol which we have set.
You showed a good laser passing through a thick scar. Are you sure it does, or you increase the energy?
Yes, we have to increase the energy. Normal if you look at the femtosecond laser procedure that we do, like SMILE and other, it's 28. 28 means 28 into 5 nanojoules. But here we have increased to 40 nanojoules.
That's one
Sorry,
point
40,
which doubts us.
Yeah,
Laser passing through a scar tissue. Second is the most common, the least told, and always never asked for is the suction break. Whether it's a donor eye or a patient's eye.
Suction, sir?
The breaks. The patient is non-cooperative and the suction breaks during.
Yeah, suction loss that we call, it's not common, because I have been doing even the SMILE for a long time. So I have encountered in 2-3 patients. So again, the pre-operative counseling is very important, sir, for avoiding the suction
Because
loss.
this patient is unable to fix, he already has a bad cornea, and you have only one fixing light in this kind of
But
laser.
with my experience of doing 15 such cases, I haven't encountered any suction loss with it, sir. And I know what you're talking about. You're saying that since there's a scarring, so suction loss will be an issue. But
and it's a
one
irregular
is-
cornea.
Yeah, but it hasn't happened, sir, because you have to keep telling the patient when you are, when you are taking the dock, when you are docking the thing, you have to keep telling, okay, B center. Then we have a system where we can see through infrared, right, that whether there is a centration or not.
That is there.
That is
Yeah,
there.
basically, because of the poor vision, he says there could be a
Yeah.
suction break, but you can keep the attention of them
Attention of
totally
the patient.
grasped. Because
And
it's,
we can keep telling them, okay, look straight. That's
Yeah.
one. And secondly, we can observe onto that infrared
Yeah. No, it's
system also.
Definitely, this innovation is not for all. That's sure.
Yeah, but it has to be there, sir, because otherwise our country will be lagging behind.
Thank you. Anyway, very good work.
no. Besides, the suture-related issues are totally obviated.
Obviated.
So that's
and
a
it has
wonderful
worked
thing.
really work, because
Yeah.
when you can do cataract through femtosecond laser.
When did you do the
this?
cataract surgery after doing this?
6
like
months,
6
6
months.
months,
Yeah.
6 months.
I think that's innovative.
All these cases over the years have no complications such as infection or
No infections, because in our protocol, it's very strict, because we are spending money on such patients, and we are keeping them regular follow-up. If any patient doesn't come well in time, I inform them personally, because they are not many, they are limited patients, say 15 only, so we can very well take control of them.
Thank you, sir.